So now we'll move on to the next talk by Dr. Musaad Alhamzah about carotid endarterectomy.
I'd like to first thank the organizing committee for inviting me to this meeting to participate and kind of talk about the carotid endarterectomy, which is an operation that I hope most of us are familiar with, expert with, and love it as we should, and also touch base on the indications and some of the anatomical stuff that we discussed, and also hopefully have a discussion about the indications of both procedures, and have a great discussion at the end with Dr. Spears and everyone in the panel. So thank you all again. I'm going to try to go in less than 20 minutes, hopefully. I don't have relevant disclosure except that I love doing the case, and I don't do enough of them, and I don't think I should be doing a lot of them for a lot of reasons that we'll be discussing. So I was asked to speak about carotid endarterectomy, and I'll just touch base on the quick epidemiology of the surgery, of its indications, some of the preoperative evaluations and operative techniques that we all know and do, and then we'll talk a little bit about the perioperative stroke management complications, as well as some results and trends that Dr. Spears has already touched on a few of them already. As you'll know, carotid endarterectomy, or carotid disease, was identified really in the early 19th century, where angiographic images show the occlusions or disease of extracranial carotid artery. But the first attempt to actually treat that was done in the 1950s, and then it was widely adopted in the 1970s and 1980s as a preventive tool, really, of disabling stroke and death. And after the publications of the landmark trials in the 90s, it drove the adoption really up, especially for symptomatic patients. But then at the early years of the 21st century, the entire trend went down for all interventions. And it's because of the improvement of the medical therapy, but as well as questioning some of the risks and the indications of the procedures. This is an example of what you can see in the US Medicare data over the years from the early 21st century. You can see that the entire carotid interventions are going down. And there are similar data as well from the Canadian institutions, as well as European data. The indications, as you all know, for carotid endarterectomy are most symptomatic patients with a moderate to severe stenosis, and it depends on which criteria you're using in your lab. It should also be considered, and this is a very I put it in red because it's a very red question here, to be considered in asymptomatic patients with moderate to severe stenosis, at whom their perioperative stroke and death rate is really below 3%, and whom you expect their life expectancy to basically exceed 5 years. And we'll touch on that. These are, as what Dr. Spears mentioned and presented, these are adopted by a variety of societies of different disciplines. This is a great diagram that's mentioned in the European Society of Vascular Surgery guidelines a couple of years ago. The blue side is the asymptomatic, and the red side is the symptomatic cases in the past 6 months. It basically tells you that the moderate to severe disease needs to be, that's symptomatic, it really needs to be offered. And as you see, the class 1A recommendation is a carotid endarterectomy and best medical therapy. And an alternative to that, as a carotid artery stenting, should be considered if high risk for carotid endarterectomy, or may be considered in some other circumstances, and we'll touch on that as well. The preoperative evaluation is extremely important to be standardized. This is just the general consensus of the NASET criteria in duplex. And the first thing we look at is the left hand side column of the diameter reduction, or the degree of stenosis, which corresponds to the velocities that we measure in duplex, but also one of the things that we look at is the ICA over CCA ratio, and anything 2 or above is basically indicative of moderate to severe stenosis, and with that we just go ahead and try to evaluate the patient for a procedure. This has its own limitations, especially if there's a high thrombus burden at the bulb, where NASET criteria really becomes a bit of an unuseful here, and we need to use other criteria. However, some labs use their own locally adopted criteria that have been validated against NASET or the ECSD or other criteria that are well established. What if duplex is not enough? What if there is some other issues with duplex, like we don't really know the anatomy around it, or there's a high risk anatomical variables like a redo neck surgery or radiated neck or some other bony or fibrous abnormality? That's probably where you need to have another imaging modality, such as CTA or MRA. MRA seems to be the very, very sensitive study over all of them, but they also somehow tend to overestimate the degree of stenosis compared to CTA, which may underestimate it sometimes, but they're all used generally these days as non-invasive tests to try to complement each other and help in the preoperative evaluation. Conventional angiography is done only in very limited, I would say, in very limited instances right now, especially in asymptomatic patients who don't need thrombectomy, since it's a very invasive procedure, and the results of it, or the values that you get of it, could probably be achieved through CTA most of the time. I'll touch base on the operative technique, and I'm sure many of the audience here are expert in carotid endarterectomy. I'll talk about the choice of anesthesia and what we know about it, position and incision, the conventional or eversion techniques for the repair itself, as well as the intraoperative monitoring and the use of shunts with the closure and completion imaging that are done either intraoperatively or perioperatively. To start with, the choice of anesthesia, it really is variable. There are people, it depends on where you're trained or where you practice or what your institution adopts, but I could see that in a large part of North America, general anesthesia is very well adopted, while local or regional anesthesia is adopted more in European countries. There have been a GALA trial, collaborative GALA study that was published in 2008, and I believe our institution was part of that. And it really showed that there's no major difference in hemodynamic changes or cardiac events or stroke or death as a major outcome of these studies. And so, anyway, either way you're doing, as long as you're comfortable and good with it and good at it, it's probably the way to go. As for the operative technique, because it's the neck, it's an extremely dangerous but a beautiful place to operate on. The position is usually with a flexed trunk with the head tilted away. If the patient is awake, you probably want to put a Mayo stand just to remove the drapes from their face. The standard versus transverse incisions are adopted. The standard ones are the longitudinal ones along the anterior border of the sternomastoid, while the transverse ones are along the crease. They provide some cosmetic benefits, but might be challenging in some exposure, especially in high lesions. The superior end of the dissection, you should end up at the digastric muscle, posteriorly at the digastric muscle, while the inferior end down at the omohyoid. We, as vascular surgeons, tend to carefully try to identify vagus as the first thing, and then go up and try to identify the hypoglossal. We also sometimes find the answer and are very meticulous and careful with it. And I won't lie when I say that I almost had a heart attack when I was operating with a neurosurgeon who just cut it in front of my eyes and said, just don't worry about it. And so maybe you guys are more comfortable with it than I am. Part of the repair itself is a conventional standard longitudinal lesion, longitudinal arteriotomy that starts from the bulb all the way up to the internal carotid artery, preferably to be away from the origin of the external carotid, just to have the repair to be a lot easier. This is the diagram where the shunt is actually in place. where the plaque is removed carefully and make sure that it's tethered distally and removed, that you see in the right hand side picture. And that arteriotomy is actually closed with a patch, as you see here. This is as opposed to the Eversion endarterectomy model. I think this was introduced by Michael DeBakey initially, but I think the neurosurgeons have become very proficient in it early on before they, most of it were handed over to us. They basically control over the vessels, open the or excise the origin of the internal carotid artery, and just peel all the plaque from it. Then do a formal endarterectomy of the bulb itself, which will allow you to do a quick re-anastomosis and reattachment. It's also very useful if you have a kinked or a long internal carotid artery where you can trim some of it and cut it to length and reattach it with a wide anastomosis that is less prone to restenosis. Patching can be difficult. It's not really, shunting can be difficult here. It's not very prohibitive, but it can be difficult and time consuming if you're not familiar with it. And it also, as a disadvantage, it requires more extensive dissection of the vessels that you probably don't need with the standard endarterectomy. The last thing that is very important here is the distal ICA flap might be difficult to visualize even with a full eversion. One would ask, what was the difference between the eversion or the conventional carotid endarterectomy? And the answer to that is probably no major differences detected if you're comfortable with either technique. The only thing that was observed really is that eversion technique was associated with some lower, a little bit of lower rates of restenosis on the long run, and that's probably related to degree of the patch or the intimal hyperplasia that is usually developing in some of the arterial repairs sites. The intraoperative monitoring or the use of shunt is a very controversial thing, and people tend to be very religious about it. Many people, especially early on, were non-shunters and used to be and continue to be non-shunters. And in the Gala trial, I believe less than 10% of the operators were non-shunters. Most of the people who operate globally are routine shunters these days. As you get comfortable operating on a carotid artery, some people tend to be selective shunters, and they use shunts depending on what they see intraoperatively. Those folks either do a stump pressure by essentially occluding the common carotid or clamping the common carotid and having an art line tubing with a catheter insert in the internal to determine the stump pressure. And if they're happy with it, then they just go on without shunting. Some of them adopt a transcutaneous Doppler detection of flow in the middle cerebral artery, which somehow showed that the results of the incidence of strokes is approaching 5%. I think they're just seeing some debris and stuff the more they clamp or manipulate, but the clinical effect of that was not really reported much. The evoked potential recording is employed, the somatosensory ones, where they put some needles in the hands and legs and feet to detect if there is any drop in that, where they would have to insert the shunt. Or for those folks who use it under local anesthesia, essentially when the patient starts to have symptoms, they would probably go ahead and shunt it. These are the two major types of shunts, either a straight one, the Javits shunt, or the other one that's basically turned around and more versatile one, which is a Pruitt and a Hara one. They're both are good for use. Many people are using either or. The Javits shunt is, I think, used with some or associated with some a little bit more flap or some dissections that are minor while using it, but that's not been very, very different from the Pruitt and Hara shunt. As for the closure, which is a very, very important, the stroke rate for routine shunters is 2%. Sorry, these numbers are opposite. I'm sorry about that. The routine shunters has a 1.4% stroke rates, preoperative stroke rates, compared to the non-shunters who had a 2% stroke rates. I'm sorry, again, that's the opposite. As for the closure, early on, the arteriotomy was closed primarily, and a longitudinal arteriotomy that's closed primarily will definitely lead to stenosis and probably restenosis of the lesion versus patch or eversion. As we know, eversion now has a lower rate of restenosis even compared to a patch. These two modalities have lower perioperative stroke and death rates compared to primary arteriotomy closure, and that's why it's probably standard of care right now to close the arteriotomy with patch if you're using the standard technique. Then we'll talk about the completion imaging at the end of the procedure. Usually when we close and unclamp and reestablish flow to that part of the brain, we examine that with a Doppler to detect the signal proximally and distally and make sure everything is okay. Sometimes we're not quite sure if we try to bring duplex, but it's also operator dependent. And I can tell you that vascular surgeons are not very expert in actually performing duplex themselves without proper training. That's the most common modality we use as a completion angiogram. The angiography is very rarely used, and I think it's been abandoned now just because of the positioning of the patient and the difficulty of doing it. And most of the time currently it's done through the same incision by inserting a small catheter in the common carotid artery. And the question becomes really when to reopen if you see something, if you see a small dissection of flap, or if you see a floater, or you see a little thrombus. When do you really open, especially if the patient is under general anesthesia? And that takes us to the perioperative stroke management. When the patient develops symptoms under local anesthesia after closure of the artery, then the decision is really easy to reopen and explore it right away to make sure that there is no flap and there is no acute thrombus forming in the area. If the patient is under GA, we usually stay scrubbed until the confirmation of the neurological status when the patient emerges from anesthesia, and make sure that they move the contralateral side of their body. They don't have major deficits in their cranial nerves as well. Very rarely, when they have those deficits and they're very clear, we tend to go back and reopen right away. These questions are kind of easier compared to when the symptoms or the deficits actually develop in the recovering room. It becomes more challenging, and if available, we can do a quick duplex exam to just rule out acute thrombosis of the area of the operative site, which might be difficult given the recent decision. And therefore, the differential diagnosis could be just a transient ischemia due to the clamp or embolization or some other factors, and we tend to anticoagulate them right away and sometimes take them to the CT scan if we're not sure if the cause of that, if the cause of the symptoms is actually thrombosis of the area. I'll touch base on the complications in general, and I just remind myself and everyone that the goal of carotid endarterectomy or carotid stenting is to prevent future strokes. So it's primarily a quality of life procedure or procedures that we're doing. The major complications that have been, especially in the contemporary trials, the major adverse cardiovascular outcomes. And as Dr. Spears touched on them, there are MI, stroke, or death, and stroke is usually re-stratified or subgrouped into ipsilateral stroke or immediate stroke, or either temporal or site of stroke stratification. MI is the cause of death in about 25 or 50% of cases after carotid endarterectomy, and that's why even in the CREST trial, despite the objection, I would say, from the vascular surgeons that the results are not the same, it's hard to say that just troponinitis is not a predictor of increased mortality down the road. The other complications are related to the surgery itself or the site of surgery, the cranial nerve injuries that could happen anywhere between 5 to 20%. And the reason of that is simply because we have nerves everywhere around the area. Most of them is the hypoglossal nerve palsy, and most of them are temporary. The cerebral hyperperfusion syndrome is the killer. It happens about 5 or 7 days afterwards. It's rare, but the mortality could exceed 70%. And we have to really do a CT to rule out a bleed. And if there is, we have to call the good guys, the neurosurgeons, to help the patient with that. Hemodynamic instability is very common, and that's why continuous monitoring for the first 24 hours is very, very important for these patients. As you all know, the results are extremely fantastic, really, for symptomatic disease from the MENASO trial and ECSD. The asymptomatics remain controversial. The pooled analyses showed that you just need to treat 6 patients to prevent an event in severe stenosis symptomatic patients. The asymptomatic patients, despite the progression, it still favors the carotid endarterectomy when it comes to treatment and meta-analysis. And these are the contemporary results. And as Dr. Spears mentioned the results earlier, I'm not going to go again on them, but as you can see, the stroke and death rates tend to be higher with the stenting and more MI with endarterectomy. The ACT1 trial, which was published at the same day of the 10-day CREST results, was a non-inferior trial and had its own methodological problems as well, but it showed that it's non-inferior in asymptomatic disease. These are the results from the Ontario real-world follow-up in 13 years, and you could still see that the carotid artery vascularization, carotid endarterectomy tend to be severe across the board. And the main, really, as what Dr. Spears mentioned, the main drop of stenting happens really in the perioperative area, and then it just becomes parallel throughout as we go further in follow-up. And so CREST-2 is hopefully going to answer a very important question, especially about asymptomatic patients, whether or not we should actually do anything to them. And we look forward to the results of this trial. In summary, I would say that carotid endarterectomy is a durable procedure with an established fantastic benefits in treating symptomatic carotid lesions, and careful selection of asymptomatic patients is key, and further research is ongoing in CREST-2 and others. It's just because in the real world, we know now that most of the operators, regardless of what they're doing, is stenting or carotid endarterectomy, they don't really reach the benchmark of 3% risk of stroke or perioperative stroke, and that's why the selection that we have to be careful in selecting these patients. Alternative to carotid endarterectomy, whether it's stenting or best medical therapy, should be considered in patients with prohibitive risk. And transcervical carotid artery vascularization, or TCAR, showing superior results versus transfemoral approach in registries data, at least in the time being, and I don't think we will see any randomized trials comparing both of them. But I think TCAR is a very, very great technology and advancement that combines both the surgical and the endovascular techniques. And I think all of us should be, getting to know this and experimenting and actually studying this further to determine what would be the best modality in treating our patients. These are just some of the selected references, and I'd like again to thank the moderators and my colleagues here at the university for inviting me for this talk.